Okay, well, all right. Well, good morning and welcome to our grand rounds this morning, which will focus on the ankle and the lower leg. As I came to realize as I was putting this together, ironically enough, there's actually not a whole lot that has been has research-wise, but is actually focused on the ankle itself. So I kind of took that. Took the executive decision, moved into the lower leg as well. And so I just want to offer a brief outline of what we'll be doing this morning. So I'll do some introductions of myself in a minute or two. In terms of conflicts of interest, I have no conflicts of interest other than I am a member of ATRI. Not that would be a conflict, but I have no financial or product enticement during this presentation. So there'll be some products and some devices that we'll talk about that, again, I have no financial ties to. And then in terms of just some general ground rules for today's session, one is I want you to think about the question why, and I want you to question why 5 times, and I'll talk more about that in a second. I also want folks to ask questions at any time. I actually have the chat box shut down, so if you have a question, just ask. I can't multitask the video, the PowerPoint, and to chat at the same time, so just ask questions. Obviously, share your experiences and your expertise along the way. And then we want to make sure we try to promote collegiality. For those of you that don't know me, my name is David Berry, and I am a professor and department chair of kinesiology at Saginaw Valley State University in University Center, Michigan, which is right next to Saginaw. I'm actually an athletic trainer by profession and have been for 25 years, just about. I have been a member of ATRI now for, I don't know, 7 or 8 years. And I've been certified for about that long as well. And I speak occasionally for Ruth here and there on topics usually relative to athletics or athlete rehab, but also in terms of research as well. I teach an evidence-based practice course here at the university and have done a fair amount of evidence-based practice, scoping reviews, systematic reviews related to aquatic therapy. And that's really kind of how I've structured this grand rounds session today on the ankle and the lower leg. So there we go. All right, so why are we here today? And so I want to quickly take a second to talk about really what are grand rounds, because I think sometimes having an understanding of what it is will help to understand why I'm talking about what I am later on. And so it generally is an opportunity to provide an update relative to a diagnosis or treatment. It's the opportunity to provide updates into healthcare research, which is really kind of what we're going to be looking at today. It does promote, again, collegiality among colleagues. It's often used for continuing education, as it is being done for today, as well as an opportunity to mentor professionals within a specific discipline. And so today we're going to take it from the perspective of providing updates into healthcare research, again, specifically as relates to aquatic therapy. I also want to just take a minute or two to talk about this idea of root cause analysis. And root cause analysis is actually a healthcare concept, as well as a concept that's used in manufacturing as well. But it's a process of discovering the root cause of a problem in order to identify the appropriate solutions. What it does is it helps to assume that there's more effective processes when you understand why something is happening versus just having a knee-jerk reaction. So for an example here, instead of just treating the symptoms of a football player's concussion, we can begin to take a root cause analysis, which might suggest that wearing a helmet will help to actually reduce future concussions. But again, why is that the case? And so if you think about the concussion in an athlete, particularly a football player, for an example here, I'm going to kind of first look at first our play will present with some sort of problem. And in this case, we're asking the question is, why do I have such a bad headache? Or the athlete's asking, why do I have such a bad headache? And so this becomes what we know as this becomes known as our first why. Okay. And the answer for this is because I can't see straight. We then ask another why. Well, why can't you see straight? Okay, so it's not just taking the first at face value, but I want to ask that second why. And our response to this might be because my head hit the ground. And then we ask the third why. Well, why did your head hit the ground? We get a response. I got tackled to the ground and hit my head hard. And then we ask a fourth why. Why did hitting the ground hurt you so much? Answer, because I wasn't wearing a helmet. Fifth why. Well, why weren't you wearing a helmet? The answer, because we didn't have enough helmets in our locker room. And so you've systematically identified what the problem was, right? We often go try to treat the symptoms, but we don't know the whys. And the point of this is, the reason why I'm bringing this up right now is that as we talk about these three studies this morning, we're going to try to look at the why. And I want you to always constantly be thinking about the why along the way. And it's great that we know different exercises and procedures to go about treating specific pathology. But if you don't know the why and what the benefit is and how that why affects that downstream effect, then a simple balance exercise in of itself might not be exactly what you want because you don't know why. So with that said, let's kind of move into the first article. And so the first article in this case, we're going to start with a little bit of a background for all these articles. And for this first one, we're going to start with this idea of, we all know as healthcare professionals that chronic lower leg edema is a multifactorial condition, as expressed here. It's often associated with a failure of the venous and the lymphatic systems. And this actually represents the most common etiology of lower leg lymphedema in patients greater than 50 years of age in westernized countries. In fact, up to 30% of advanced chronic venous disease, or what's known as CVD in this case, presents with associated lymphatic impairment. And in addition, recent evidence has demonstrated that the incidence of venous lymphedema is often underestimated. And considering the potential misdiagnosis among primary lymphedema in the cases of iliac venous obstruction, we end up with development of this idea of secondary swelling, which then can begin to compromise the system further. We also know as healthcare professionals how frequently this condition, that is lymphedema, is encountered or is often seen, and how high the related economic costs can be associated with this condition. The problem with that is despite the known prevalence of the condition, it actually is believed to still be underestimated in a majority of patients. And from a management perspective, we know that manual lymphatic drainage, particular skin care, pharmacological support, and compressive devices represent the mainstay treatments for patients with lymphedema. However, we're asking the question today, or I'd like to ask the question today, what is the applicability though of aquatic therapy, specifically related to the ankle on chronic lower leg edema? And so how does aquatic therapy play into management both of CVD as well as how does it actually affect the ankle? And so the first article we're going to look at is entitled a specifically designed aquatic exercise protocol to reduce chronic lower limb edema. And this is relatively new. It's a 2017 paper from phlebotomy. So within the article, there were two primary objectives. And the first one here was to evaluate the effects of a specifically designed aquatic exercise protocol on a leg volume of hypomobile patients affected with chronic lower limb edema of venous and lymphatic origin, as well as to look at the modifications of ankle range of motion, the symptomatology, as well as walking ability, which we know is going to be influenced by ankle function. In this paper, there were 16 patients who volunteered as participants, which then resulted in 32 lower limbs. All patients were affected with bilateral lymphedema. There were 12 females, and that would make what, 14 males. The ages in this case was 60. The mean age rather was 60 plus or minus 5 years. There were 14 cases who presented with visible varices, and I'll give you a little bit further breakdown in a second here. 2 patients were affected with bilateral lymphedema secondary to surgical and radiotherapeutic oncologic protocols without any venous drainage impairment. Specifically, when you break down the chronic venous disease by its associated classification system, you had 9 subjects that had, varicosities. You had 16 subjects that had the edema or the swelling that's often seen with lymphedemic patients. You had 2 that had what they call C4 classifications, and they did not specifically break down the C4 classification, whether it was an A or a B, that just that it was a C4. And then they had 1 that was a C5 patient where they had healing of the wounds that had been associated with the damage that's often associated with having the swelling in the lymphedema patient. In terms of the inclusion and exclusion criteria, and this is something that is often neglected when we look at research, but it is important, I think, to understand who we accept and who we reject, for the sheer fact that it does influence how we would apply this topic to a specific patient population. And so in this case, you had subjects who had to be greater than 18 years of age. They had a diagnosis of chronic venous disease. They had pitting edema or a positive Kaposi stemmer test, as well as lower limb edema onset greater than 3 months. They were excluded, though, if they had previous varicosity procedure, if they had previous lower limb trauma, they had heart, respiratory, renal failure, they had rheumatological disease, and if they had fear of the water. Just in terms of what a stemmer sign is, a stemmer sign is the inability to bring the skin folds together on the dorsum of the foot at the second toe. When you're unable to bring the skin together or basically tent the skin, that is considered to be a positive sign for the diagnosis of lymphedema. And so the intervention in this case is that all patients underwent a protocol of physical exercises specifically conceived inside a pool and designed to maximize ankle motion together with the calf and plantar muscle groups. The pool was a 4-foot had a 4-foot depth, so it was a therapeutic pool. The temperature was maintained at 33 degrees Celsius or 91 degrees Fahrenheit, and pH, chlorine, and water clarity were checked on a daily basis. The protocol the protocol that was used in this study, they named it the Hydro-FE protocol. Now, one of the reasons why I like this paper and one of the reasons why I selected it to have the conversation this morning is because when you look at a lot of aquatic therapy research, and this is one of my pet peeves, is they talk about this procedure that they did, this aquatic therapy intervention, yet they are ill-defined what types of what the exercises were, what depths they were done at, or many of the items that we would need to be able to replicate it for a similar patient population. And this study actually did a fairly good job of identifying what the actual protocol was. So it was a 10-step protocol. And in this particular study, they started with warming up by cycling-like activities in the supine position while holding a handrail. Okay. All of these exercises were performed under the supervision of a personal trainer who had experience in hydrotherapy. The patients also performed these exercises for 2 sessions a week for a total of 5 sessions. So essentially did this protocol for about two and a half weeks. And so they began with this first activity. This was followed by a tip-toe exercise, and where they did 4 series of 10 reps each. They did a hip flexion extension exercise on the non-weight bearing limb for 4 series of 10 reps each. And of course, this went, they did right leg, left leg, because both limbs were affected here. They did a tip-toe exercise on a step, again, 4 series of 10 reps. They did a knee flexion extension at increasing velocity. And I think this is one exercise to kind of keep in the back of your mind for a few minutes here. They also performed backward and forward walking for 5 minutes. They performed a lateral walking on both sides for 5 minutes. They performed a cycling-like single push while standing up on the contralateral limb, holding the kickboard for balance. They did ankle flexion extension exercises while keeping the knee bent at 90 degrees. And then this was followed with a cool down, again, with the cycling-like activity back in this supine position. And so these 10 exercises, when done bilaterally, took, again, roughly 50 minutes to be able to accomplish. And so the outcomes then that were assessed in the study is that prior to the first session and 1 week after last, the subjects all underwent a high resolution echo color Doppler to evaluate venous drainage and subcutaneous tissue thickness. They looked at circumference using a centimeter tape measure pre and 1 week following the 5 sessions. They looked at ankle dorsiflexion, ankle range of motion, specifically dorsiflexion and plantarflexion in the short sit position. So they measured it using a standard goniometer and the standard goniometric process. They also measured limb volume pre and post every session to look at resolution or changes in the amount of edema formation in the ankle and the lower leg. And so what happens here with this particular device is the limb thickness displaces water. So the amount of water, the more water displaced, the more limb mass that's being put into this, what's referred to as a velometer. As swelling resides, there should be less water displacement taking place. They looked at the first week post protocol. They looked at a 100 millimeter visual analog scale to look at feelings of lower limb heaviness. And then finally they assessed functional ambulation classification, which basically looked at the ability or looked at the person's ability to be able to walk. And so in terms of the results that were found here, what they did find is they found that there was the water displacement did report a significant average reduction in all the lower limbs volumes before and after the hydro FE protocol. And so what you see here is that in this case, they're measuring the right leg in this highlighted box here, and we see our pre volume fluid displacement versus the post at the conclusion of the 5 sessions water displacement. So you see a reduction in the amount of edema that was in the patient's limb, as well as in their ankle. And then this green box is going to be the left side as well. And so you had very similar volume changes in the right and left limbs pre and post activity. When they did the water displacement between sessions, they did find that between session 1 and session 2, there was a difference. So from the first session to the second session, the patients showed a reduction in limb volume. From sessions 2 to sessions 3, there was a reduction in limb volume. From session 3 to session 4, there was a reduction in limb volume. The only session that did not have a reduction was between sessions 4 and sessions 5. And so whatever reason, they kind of peaked out at session 4 here in terms of changes in limb volume or limb mass. They also found a significant volume reduction among all patients from baseline to their final assessment. And so each of these individual lines here represent essentially a patient. And this shows the amount of volume reduction in their right legs and in their left legs from their pre-session to their post-session. So everybody demonstrated in this case a significant reduction in limb volume. They also found within this protocol that at 1 week after the end of the protocol, the subcutaneous tissue thickness, as well as their circumference, also had a significant reduction. They found down here on the bottom here that range of motion, they had a significant increase in both the right as well as the left ankle dorsiflexion and plantar flexion. And they also found a direct correlation between a limb volume and circumference at different points in time within the right and in the left leg. Okay, so given all that data, we now want to ask kind of the question why. So we saw changes in limb volume, we saw some changes in range of motion, we saw changes in circumference. And so now we ask the question why. And so kind of the first answer that I have here, and again, some of this probably makes sense and you probably already know the whys, but this is where the importance, I think, of having the conversation is that when you start to go to the application in a real patient, knowing the science behind this is what makes this application beneficial and what gives you the clinical expertise to make sure you're selecting the right activities. And so the first why here is that, according to Stevens law, the pressure at a point in a liquid in static equilibrium depends upon the depth at that point. And so in this case, P, which is pressure, equals P0 plus D times G times H, whereas P is the external force, external pressure on the surface, H is the depth, G is gravity acceleration, and D is liquid density. Now, one of the things that we're probably all familiar with is that we know that this, with the idea of hydrostatic pressure, particularly of water, that as we lower a limb into the depths, into water, we have roughly a 0.74 millimeter mercury change for every centimeter that a limb goes into. This, of course, begins to increase or favors limb drainage. Now, we tend to think of this more, I tend to think of this more so when you have joint edema, which is more of a liquid substance, versus lymphatic material, which is more of a heavier, dense subject, or dense matter rather. But nonetheless, one of the reasons why you had the volume changes does tie back into this idea of limb hydrostatic pressure. Water hydrostatic pressure, sorry. We can also ask, there's also another why that we could ask. That is, why did these changes occur? And I'm gonna throw out a hint here and see if anybody can come up with this one. And the hint begins with the V. I'll throw it out there for a second. I know there's a handful of you on. So why else? So in terms of thinking about the root, not volume,
No,
Venous return?
not venous return. Think of it from a therapeutic perspective.
not viscosity.
Yeah, viscosity.
Okay.
So
I have
viscosity.
another question later, so.
Okay, sounds good. All right, just let me get through the study and then we can
that's
then
fine.
ask the question. So the viscosity in this case, we know provides a resistance that promotes the strengthening of the calf muscular action on the venous and lymphatic systems. So essentially, right, if you think about that, some of the activities they were doing were range of motion activities. Well, to do the range, and particularly of the knee, and as they did the range of motion activities, they were, number one, strengthening the quadriceps and hamstrings, but by virtue of doing those activities, they were doing ankle and dorsiplantar flexion, ankle dorsey and plantar flexion, and that ankle and dorsiplantar flexion was allowing for venous and lymphatic exchange to occur, which is another reason why then you have the reduction in limb volume. So it's not just enough to put somebody into water and use the water hydrostatic pressure to cause a change, but in this case, the viscosity is also aiding in that, or one of the explanations why it aids in that process. Another why, and I'm gonna give you a hint here too. It's think pumps again, and not shoes. And I've already kind of given you the answer here. So what about pumps? How do pumps influence lymphatic drainage or edema drainage?
How the way the heart's pumping the blood through the veins?
Okay, good. That's not a topic area that I had thought about, but that definitely would be one thing.
Okay, does that pumps refer to a shoe as in a heel or a
Well,
pump?
it's not a shoe. Nope. It's
But
not your shoes.
like a wedge?
Not a wedge.
The venous pump returning, facilitating venous return. So the pumping action of the muscles in the.
Yeah, exactly. Yeah. So we go back, and that's why I said I kind of already gave you the answer here. I kind of got ahead of myself here. Is that idea of that dorsiflexion plantarflexion action influences influences venous blood and lymphatic return. And so we know we do this on land quite a bit with people who are post-surgical. And the reason we do that is to help prevent stasis of the fluid, number one, but number two, it helps the drainage process. The other part to this too, and when you're in the water, is so of course you have that advantage of the water hydrostatic pressure, which helps push fluid back in order to increase that return. But that movement in the water as well, that is the dorsiflexion plantarflexion movement that we get here, it also changes the length of the vascular structure. And that is really kind of the other component here is that influences it, is that you change the cross-sectional diameter. And as you change cross-sectional diameter, make it bigger to smaller, that pressure within the vascular structure still has to push fluid back now, because it's gone from one size, a bigger size, to a smaller size. Particularly the saphenous vein is put on stretch. And so in conclusion here, or the conclusion for this particular study in terms of an application here, is that they did find that there was objective and a significantly positive outcome of this particular protocol in reducing lower limb volume, as well as affecting ankle range motion. Now, one of the other components that is talked about or can be thought about here too, and then I didn't spend a whole lot of time addressing it in the slides here, is the idea that remember, these subjects also did forward walking as well as side walking or lateral walking. Both forward walking and lateral walking have also been, as well as backwards walking or retro walking, have also all been shown to improve the venous and lymphatic drainage as well. And again, that often ties back into that concept of the stretching of the vasculature as well, which helps to push fluid back out. And so this protocol then, and again, you have the reference to be able to pull this from online, because it is a free full text article. You'll be able to grab a protocol to then at least have a process that over the course of four therapeutic events or four therapeutic sessions, began to show some significant changes in these patients who presented with a wide range of, again, wide range of lymphedema within their lower leg and ankle. Okay, so I know somebody said they had a question, so shoot your question and I'll try to answer it.
Okay, David, it's Linda.
Yep.
Were any of these patients that were on the study, were they taking any kind of diuretic medication or drinking more water to help with their circulation?
Now that was not mentioned in the study.
Okay,
Certainly adequate hydration is a key, is key to making sure that you have good fluid movement from a blood perspective, because half of our blood is a water content, but that was not specifically addressed in the study. But that would be something that, as an aquatic therapist or as an aquatic rehab person, it's one of those things, particularly if they're going to be in 91-degree water, I would want to make sure that they were hydrated before and they were hydrated afterwards. Again, because as we all know, we tend to forget that water and exercise and water can in fact dehydrate you just as much as being on land.
exactly. Thank you.
Yep, great. Okay, so let's now kind of digress now into the second paper that I decided to pull. This one does look at more of a younger athletic population, and this one is more specific to the ankle. In fact, that we know that the ankle joint is one of the most frequently injured joints in the body. In fact, lateral ankle sprains, that is like sprains that occur to this side of the joint. About 85% of all ankle sprains occur to the outside. But ankle sprains themselves are at the top of the list in terms of the ligamentous structures that are damaged in the body. The shoulder, I think, takes the next position in this. And so this is something that a good number of people will see within their practice, whether it be in a clinical practice or whether it be in a strength and conditioning type environment. One of the problems that I think we run into here is that when you do have that initial ankle sprain, it is not uncommon for somebody to develop some sort of residual symptoms. And one of the two most frequently reported residual symptoms are going to be this idea of the ankle giving away, or some sort of feeling of ankle joint instability. And what can happen is, and people don't necessarily think about this all that much, particularly when they talk about return to play or return to sport or even work. Well, it's just an ankle sprain. It's not a big deal. I'll go back. I'm going to go back as soon as I'm able to do so. Well, the problem is that when you look at these residual symptoms over time, this ankle joint instability can actually develop into what is known as CAI, or what's known as chronic ankle instability. Sometimes it's known as FAI or functional ankle instability. And over time, again, this is something that minor ankle sprain that somebody suffered, if it's not managed appropriately, can lead to a surgical procedure to correct this at some point in time later on. Now, relative to that, we know that ankle proprioception is, as it says here, critical to the balance of the human body during functional activities, including standing, walking, and running. We also know from the literature that FAI, or people with functional ankle instability, do show or have shown impaired postural stability, decreased proprioception, and altered peripheral control of ankle function when it's compared to a non-impaired subject. Well, what does this mean? Well, what it basically means is that when I am stepping down, or when I am taxed with a situation where that ankle ligamentous structure needs to kick in, it's not just the ligaments to provide joint stability, it's the musculature that goes around it. And if that chronic ankle instability, that functional ankle instability is enhanced with decreased proprioception or awareness of where our joint is in time and space, then I don't get the appropriate neuromuscular response to the neuromuscular control to try to correct the procedure. So essentially, when my ankle begins to roll inward on a lateral ankle sprain, the musculature on the lateral side, my peroneus longus and brevis, the muscle spindles sense the change in length here, and they immediately hopefully produce a reflexive muscle contraction to begin to bring the ankle back into an everted position so it doesn't continue to invert. Functional ankle instability, though, says that, well, we're going to continue to have this instability because that proprioception has been affected. And so my reaction speed to have neuromuscular control to pull it back out is decreased, and which is why then we constantly have problems with the ankle. And there are many studies that have looked at the effects of things like wobble boards and air disc pads on land-based people in terms of being able to increase proprioception for individuals who have suffered from a lateral ankle sprain in order to mitigate the amount of functional ankle instability or chronic ankle instability. And so this is one of the few studies that I actually did find that was decent related to how aquatic then training affects ankle instability. And this comes from the Foot Ankle Specialties. Again, this is another free article that you're able to download. Okay. And so this study has two objectives. And one is to detect functional deficits after an ankle sprain in college athletes, as well as to examine the effectiveness of two different rehab programs. So a land-based and a pool-based program, again, on this balance ability in a college age population. And so you had 30 physically active college age individuals. Physically active in this case meant that they were participating in some sort of exercise at least twice a week. And that's often the common definition of physically active. And so they range from 20 to 22 with a mean age of 20 and a half. All subjects had one functionally unstable ankle. And so they had at least one repeated injury or perception of ankle instability or giving away. They had no evidence of mechanical instability as assessed by an ortho using an anterior draw test. And they had a pain-free, full weight bearing and normal gait at the time of the study. Also, the average period of time since the last episode of instability was 2 months. And so again, the other reason why I like this study is they do provide a little bit of a description of what that methodology looks like. And again, this is, to me, is just so important. You can't replicate something without knowing exactly what was done within the study. And again, they were not as explicit as I would like, but it was not bad in terms of their balance training program. And so here is a listing of what was done with a hard balance board as well as on an air disc. And the land and the aquatic group performed the same activities for 6 weeks, exercising 3 times a week. And so both groups performed a 20-minute training program with the 5 different exercises listed above on a hardboard and on an air disc, with 2 reps for each exercises. So it was 5 exercises times 2 boards times 2 repetitions. And so it was the ability to maintain a single limb stance, the ability, attempt to maintain single limb stance and try to bend and extend the knee, attempt to maintain a single limb stance and try to move the unsupporting leg in front and back, attempt to maintain a single limb stance and try to catch and return a ball to the trainer, and then attempt to maintain a single limb stance while the trainer from the back passes the ball to the exerciser. And so what they were not specific about was what type of air disc they use, what type of board they use. But so again, I'm extrapolating here that this is an air disc on the left. This is a form of a wobble board on the right. So I'm assuming they both looked somewhat similar to these. In terms of the outcomes that they measured, they did look at what we refer to as static balance, as well as they looked at dynamic balance. And static for these, they used the Biodex stability system, which you see here. And so for the static balance test, it was a testing protocol that consisted of a single 20-second test, while the platform was set to freely move with a minimal resistance available. So they set this at level 1. And what they had to do is that this system set up with a computer screen. And so they essentially have to keep this disc or their body just on this disc standing. They have to keep it in the center in order to maintain their center of their mass. And it sounds really easy, except when you have a number 1, poor balance, or number 2, functional ankle instability, and then your ankle wants to go all over the place. And so you have a very difficult time trying to maintain the center of mass and keep that cursor in the middle of the screen. They also performed a dynamic test, and the dynamic test was a set of protocols where they have to move this platform. So this platform right here, now they have to move this platform up, left, right, diagonal, and they have predefined targets that they have to hit. So they have these targets that the computer will set, and they start at a point in the center, and they have to move maybe to 1, and then move to 2, wherever the computer tells them to move is where they move to. And they have to stay within this, they have to keep the cursor of the computer within that box for 0.5 seconds. And when that happens, then it moves to the next target. And so you are taxing both not only the muscular system, but again, you're taxing the neuromuscular control, specifically proprioception, because you're going to be able to move that disc forward, backward, left, right, or diagonal. And then once you find that point, you have to hold it there. So again, it sounds easy until you actually start trying it. In terms of the results here, and so they did, when you look at the results, all balance performance indicators between the healthy and the injured were found to be significant. However, there was no differences between the groups. After the completion of the training programs, a repeated measures analysis of variance also revealed that the 6-week training program improved all balance performance indicators in both training groups as well. And so they looked at specifically total stability, anterior and posterior movement, as well as medial and lateral movement. And again, not to bore you with all the numbers here, which is, so we're only going to kind of look at total stability for right now. In essence, these all were statistically significant across each of these. Was that if you look at the pre-training from the healthy to the injured, so this is the land group, healthy, injured, aquatic group, healthy, injured, you do see that there were significant deficits between the injured leg and the healthy leg, because they measured both limbs. Okay. And that occurred in both groups. And you see, actually, the values are relatively consistent between the groups, which is actually a good thing. When you start looking then from the land-based and the aquatic base in terms of post-training, the land group, injured pre, injured post, you see that actually got significantly better. It went from 8.41 degrees of instability to 4.41 degrees of instability. The aquatic group, 8.3 degrees of instability to 4.6 degrees of instability. And then when you compare the land to the aquatic on the post, so at the end of the training, at the end of the 6-week session, you see there was no statistically significant difference. So both groups got better from pre to post, but there was no difference between the two of them. Now, again, a lot of people think that no difference is a bad thing. Well, in this case, no difference is a good thing. It means that, number one, balanced training, whether it be done on land or in the water, using this, at least this specific protocol, demonstrates that there is an improvement in overall stability within the joint, which basically is going to mean then that proprioceptive awareness, neuromuscular control and reaction is improving. That then translates into the ability to protect the joint. And so again, we go back and we ask that question, why? And within this study, one of the things I did not mention is that there was some water turbulence that was actually added to the study as well. And so when you look at land, okay, when you're on land doing balance type activities, you have more sway that is actually taking place. We have greater changes that occur in the changes in the center of mass. When you're in the water, the pressure and the density of the water, while you can get excursions, you can get movement, it's not necessarily as great, and it tends to be a little bit of a slower reaction. And so the reaction speed between the water and the land from a proprioceptor component tends to be a little bit delayed. However, when you start to add turbulence as part of this process, the turbulence, and I know Ruth is going to love this, talks about the idea of, or introduces the idea of both a predictable as well as potentially an unpredictable command or manner, which challenges that neuromuscular system, or challenges that proprioceptive system. But more importantly, it allows for this to be done in a safer environment as well, because now if somebody was to lose their balance and fall, they're not falling on a hardwood floor. But that has to be something that's integrated as part of this process. Now, what's interesting with this is, again, there's not a whole lot of work that has even addressed the idea of perturbations in the water. One of the references that I would encourage people to go look at is this Melzer article entitled "A Water-Based Training Program That Included Perturbation Exercises to Improve Stepping Response in Older Adults." It's a study protocol. They actually reference back a functional and specific balance training program, which is a 5-level program that comes from this Mansfield paper. And so again, I pulled this particular paper. I didn't pull this paper for the study, but as I looked at this paper, it's a really nice paper if you want to have a very specific proprioceptive balance training protocol. It was very detailed for the 5 levels. And again, we could spend a whole session just talking about those particular activities and what was done there. But nonetheless, when we started to then kind of look at this idea of aquatic therapies, specifically on ankle proprioception for ankle instability, we begin to see kind of the whys. There are changes in how this can actually benefit patients. Are there any questions that I can answer on that? Let's take a look at this, then this last paper. We have about 10 minutes left here. So let's look at this last paper. And this last paper is actually, the last paper we're gonna look at is actually a very new paper. It's actually a 2020 paper. But I found this to be fascinating from the perspective, from a biomechanical perspective. And that's something that I think is often neglected as well when we look at aquatic based activities. You know, we know that deep water walking, we know that shallow water walking, we know forwards and backwards, we know it's beneficial. But I'd ask the question is, well, why is it beneficial? Or better yet, why or how is it actually then affects the person from a mechanical perspective? And is there a difference between healthy versus injured individuals? And so this kind of then starts to lead into our background for Article 3, is that, you know, we know it's well documented that gait rehabilitation in the water is very effective for neurological impairments. And I list a handful of papers there. But it's not been documented, at least prior to 2020. It had not been documented what was the ideal gait training aquatic gait training rather, in people with a traumatic brain injury. And as healthcare professionals and aquatic professionals, it's very possible you're working with TBI related patients. Now, TBI, remember, has gradated levels. A person who has a concussion is actually identified as having a mild traumatic brain injury. So it is still a traumatic brain injury. And so even this person may have some potential benefit. And so the paper we're going to look at here is aquatic treadmill walking at 3 depths of water in people with, again, traumatic brain injuries. And this is from the Physiotherapy Research Institute, I believe is what it is. And so their objective was to examine the kinematics and the spatial temporal gait patterns of aquatic treadmill walking at 3 different depths of water. That is waist, chest, and neck. And again, in people with TBI. Spatial temporal, just as some definitions here, talks about having both a spatial as well as a temporal quality. So basically, where's somebody in space and time? And then kinematics is looking at motion points of an object, as well as groups of objects. And so it's basically looking at, or sometimes defined as, the geometry of motion, which is how most biomechanical studies, what's what they're evaluating. And so in this case, they had 15 subjects, and this was a study of convenience versus a randomized sample. And so mean age was 43.2. Average years after TBI was 12.67. So this is not your concussion-based population. Rather, this is people that have had had a bilateral paresis, or basically had a partial paralysis. And paresis is a muscular weakness caused by nerve damage or disease. Specifically, you had 7 that used no walking aid. You had 7 that used a walker, and 1 used a walker with an ankle foot orthosis on both legs. Again, inclusion criteria: diagnosis of TBI by a physician. They had the ability to walk with or without an aid for 10 minutes. They had the ability to follow a test protocol, and they had no surgery within the last 6 months. And on the exclusion side, surgery within the last 6 months, orthopedic or peripheral nerve injuries to the lower limb, severe cognitive and/or behavioral disorders that interfere with study participation, uncontrollable seizures, non-ambulatory in nature because they had to be able to walk. And then they had an acute illness that would have influenced the results. And so what they did here is they were in a university pool. There's a therapeutic pool at 89 degrees Fahrenheit. They used a treadmill, aquatic treadmill from AquaGator, and they walked in 3 different conditions. Again, waist deep, the level of the anterior superior iliac spine; chest deep, level of the xiphoid process; and then neck deep. The water depths were kept consistent. This is something you don't see in a lot of studies. And this is actually one of the I would consider a big positive of this study is that they were able to keep the water depths consistent for the patients because they had an adjustable, movable. They were able to adjust a movable floor pool. And so the photo on the left here is the company that actually makes the pool. This is the photo I was able to pull from their site, but the pool deck actually rises up and down in order to be able to accommodate the height. So when they truly say waist deep or truly say chest deep, they were able to measure that regardless of the person's height. They were able to maintain that consistency. And then this photo on the right was the aqua trainer that they were the aqua treadmill that they were actually using by AquaGator. Within the study design, they actually used waterproof markers. And this photo on the right is not the actual study, but it gives you kind of a visual of what they were basically doing here. The participants completed 3 trials of 2 minutes of treadmill walking at each condition, with a 2-minute resting period between each trial. And then they randomized water depth, which basically means they started maybe with waist on one subject and then started with chest on another subject. And that helps to reduce risk of bias. And so in essence, this study data, the data was collected at one time for each participants with a rest period in between. That is in between each water depth. And so again, these were the variables. So from the spatial temporal, they looked at cadence, so the turnover of the limbs, the stride length, as well as the stance and swing time ratio. And then for the kinematics, they looked at peak sagittal plane angles, as well as range of motion of the hip, knee, and the ankle joints. The results did show a significant difference in spatial temporal, as well as kinematic gait variables across the three conditions. So waist, chest, and neck, specifically at stance swing ratio, the peak hip flexion, the overall hip range of motion, as well as peak ankle dorsiflexion. And so the next couple of figures here are going to be kind of busy. So I'll try to explain these as we kind of go and highlight the important stuff here. And so this was your overall table of results. And so this first one is the differences in the swing ratio between the water, between the chest deep, and between the neck deep individuals. This blue box is the difference in hip flexion range of motion between the water, and these are peak angles between the water, between the chest, and between the neck. So you have more hip flexion at waist deep and less hip flexion in the neck. You have overall hip range of motion was statistically significant, 41 degrees at 41 degrees of overall hip movement, 37 at the chest, and 32 at the neck. And then the last difference here was ankle dorsiflexion, which we see 12 degrees at waist, 15 degrees at chest, and 22 degrees at the neck. From a kinematic perspective, there was from the waist to the chest water depth, hip flexion decreased by 9%. And so what you're looking here in this particular figure, this is the degrees of hip movement. And this is from 0 to 100 is the gait cycle that you're looking at. And so what they looked at, again, was the peak angular structures here. And so the water is this bold line here, the chest is this green line here, and then this neutral is this red line here. And when you went from the waist to the chest water level, so waist to chest, hip range of motion decreased by 9%. So you can see that difference here. All right, this is the peak of the waist. This is going to be the peak of the chest. From the waist to the neck, they saw a decrease in hip flexion by 15% rather, and hip range of motion overall by 21.7%. When you look at the ankle dorsiflexion decreased 28% overall, and the stance ratio, as I said, decreased by about 17%. Specifically at the kinematics here, from the waist again to the neck level, okay, which is going to be right in here, you had a dorsiflexion or ankle dorsiflexion decrease by 45% from 12.6 to minus 22.2 degrees. And then from the chest, which is up in here, down to the neck level, you had a decrease in 29%. Sorry, and we're actually looking at it from over here. These are the peaks over here. I apologize. These are the peaks over here. And so this decreased by 29% from minus 15 degrees to minus 22 degrees. All right. when you look at waist to neck depth, waist to neck level water depths, again, dorsiflexion decreased by 45%. Well, this decreased peak dorsiflexion may be associated with increased buoyancy effects when the water becomes deeper. And this is where we start getting into the why. So when we start thinking about ankle activities, in this case, gait related to the ankle, okay, the depth of the water that we're at will influence the overall effects for the patient. And so in healthy patients, Jung found toe walking throughout the gait cycle as water depths increased from chest to neck level, which did not allow subjects to walk with proper ankle mechanics. Now, this is something that if we stop and think for a second, right, as we all have been in the water, we know that the deeper we get, of course, the advantage of being in neck deep water is we have about a 90% removal of complete body weight, which you have then the buoyant effect. Well, with that buoyant effect, though, this person now ends up being on their tippy toes. And so if you're thinking about a gait training activity, which is why I really like this article from an ankle perspective, is that yes, it's specific to TBIs, but if I take that lateral ankle sprain and I'm trying to do gait training, the water depth really is going to make a difference, because if I want them to work on ankle dorsiflexion, well, being at neck level water is probably not where I want to be. Rather, where I'd rather be is at the waist level. Thus, neck level water is not going to be ideal, an ideal environment for people that have a neurological disability to gait train, particularly if you want to look at optimal ankle joint movement. We also saw that there was a significant decrease in hip flexion at both chest and neck water depths compared to the waist as well. And we'd ask that question, why? And in this, the answer to this is that according to Archimedes' principle of buoyancy, where FB equals PGV, where FB is force of buoyancy, the fluid density is P, gravitational acceleration is G, and the volume of displaced fluid is really going to be the one of the rationales, or the why, as to why hip flexion at why there were differences at both the chest and neck water depths when compared to the waist. And this has to go back into the idea of center of buoyancy as well as center of gravity. In that, when walking in deeper water, the participant's body was more fully immersed. Thus, it increases the force of buoyancy applied to the center of mass. This then has a causative effect there, right? So it's great that buoyancy is our friend for some things. In the case of gait training, though, right, water depth, it does influence, though, how much proximal control a person's going to have. And so the deeper you go, if you're focusing on gait training, which is the point of this, is that increased buoyancy as you get further down in that water, as you get the buoyancy displacement, it's going to have reduced trunk stability. And while that might be great to improve trunk stability, when you're talking about gait training and gait control, you do lose proximal control, which then ultimately affects things like the hip, which doesn't allow then for the appropriate stance and or swing phase to occur. And so this can be then problematic for a patient who has to relearn how to walk after an activity. We also found that there was a significant decrease in the stance swing ratio from waist to the chest depth of water. And what you're seeing here is a gait cycle from the stance phase all the way over to the swing phase. So what you have then is the initial contact of the black leg to the loading response. We have basically full weight bearing here or start of a full weight bearing rather, to the mid stance. We have this idea of what they call single support, to the terminal stance where this white leg now is swinging through. It's often referred to as the part of the swing phase here. to then kind of migrate then into what then happens on this particular then black leg. So this is kind of the stance leg here, and then they're breaking this down to the swing phase here. The reason why I bring this up is because the results of the study also influence this too, is that we know that the shorter time in the stance phase, you're going to have a longer time it's going to be in the swing phase as the water becomes deeper. This is opposite though as to what happens on land, which can also be a problem for gait training. And the reason for this is that the increased upward thrust force from the buoyancy also influences or contributed to the increasing swing phase by eliciting an earlier initiation of the swing phase and delaying this, what we call this terminal swing right in here. Essentially, the swing phase has to last longer in order to work itself through the density of the fluid. And of course, the quicker the swing phase, the increased viscosity, the more resistance, but the longer, the less stable control that you're going to tend to have on that stance leg. And so these are all factors, all some of the whys as to the reasons why there were differences. Long and short here is that we then know that in this case, traumatic brain injured patients, there is an alteration in the spatial temporal as well as the kinematic gait variables as the water depth changes, which basically means, long and short, is that walking in neck deep water is probably not ideal for gait training. In fact, waist deep seem to have been the better water depth in order to retrain gait, particularly in a traumatic brain injured patient. You could even go so far as to say that chest deep water will work as well. And so as you kind of begin to work with patients with either TBI, or again, I would even argue with an ankle issue, that water depth is a critical component to think about as it relates to gait. And you want to be able, the idea of the water is to reduce buoyant effects, to be able to get people into the water a little bit quicker, but you don't want to alter mechanics so much that when they get onto land, they have a difficult time transitioning. And so I hope with my conversation today, or the conversation today we presented on the 3 studies, it started to think about some of the whys. Again, as I try to teach my students here at the university, it's great that a study can tell you that there's a difference, but you have to start thinking about the why and what is that implication on that patient, or patient population moving into the future. And I hope that is what I was able to bring about this morning. So, any questions? I know I'm a little bit over on time, but any questions? Glad to take them.
I don't have any questions. I just want to say, David, it's Sally. Hi. I always love being at any of the things that you do, because you do such cool research and present it in a way that everybody can understand it. And I really appreciate that.
Well, thank you.
And I love the New England accent too.
I still have it. 25 years of being outside of
Especially when you have an idea.
Yes, I have lots of ideas. It's okay. My son's name is Tyler, and we probably spend more time calling him Tyler than anything else.
He has a question.
Just a quick one, David. Thank you
Yeah.
for thanks for going over some of the research for us and looking at the implications. I'm wondering if they controlled for body composition in the depth analysis study that you just did.
No, they did not control. If they did not control for body composition, which I think, Connie, is a great point to think about, right? What is the specific density of that particular patient? Because that will definitely influence that the amount of buoyancy that's of course needed. And the denser we are, of course, we're going to be that sinker, which means we may not have as much, we're not going to have as much upward thrust. So that tippy toe walking may not have occurred quite as much in those patients, which of course, than those that are floaters, would have had more tippy toe, and of course would have had a change in center of gravity as well. Now, I think the way which they were probably able to counteract that effect is because they were on the walking treadmill. The patient was able to, number one, they were on a movable object versus kind of being in that static position. And two, they were able to have a counter force by holding onto the handle. Because
that brings upper extremity strength into stability, which is going to change the result. I mean,
Yeah,
research in the water is so tough.
yeah, and so that's another great point to bring into this. And that's the great thing about research that I love, is that, and that's, I think, the reason why you do talks like this, is that that never was addressed in the paper on how upper extremity strength and or what types of hand grip strength did a person have. That very much could have gone into helping to control the core, which then would have helped to alter, or would have helped to allow for a better swing phase, maybe. It would have helped to maintain that core, which would have prevented that proximal loss of stability. Yeah, all really great questions, which I don't have an answer for, but it goes back to asking the why, right? So you've already asked two more why questions, and we've given you why, we're giving you answers, but those two questions give you two more whys. And so it's I always go back to the idea that it's great that somebody showed you how to do this, right? Somebody showed you how to do a balanced activity using a noodle in the water. But why did you do it? And is that why always going to be the same with each patient? And so you have to, and again, you all know this, you have to treat each patient as an individual and not as a group. And that you need to avoid the cookbook process for rehab, and you need to avoid the cookbook process for aquatics. I think it goes in the exact same for this as well. And so, yeah, great comments, great pickups on the last paper. That doesn't surprise me from you, Connie.
This was excellent, David. Thank you so much.
My pleasure.
This was so worth the time to give it.
Yeah, thank you.
I actually had a lot of fun putting it. I had a lot of fun putting it together, because I took it from a perspective that I don't normally do, and I think taking it from that root cause analysis was that didn't come about until kind of near the end, as I had put the first draft together, and I didn't like what I had, and I really kind of started thinking about that whole why component. And I love
that why element. I think that is really cool. It makes you think a lot, because some of those whys are whys that, oh yeah, sure, of course you know that why. But then it was like, really? Keep going with those whys? Why did you hit your head hard? Why? I thought that was awesome.
Okay.
Awesome.
That was great.
Made me think on a Sunday morning. Yeah.
There you go. It's always a good thing.
We'll have you do more, David. And
Okay.
thank you very much. Bye, everybody.
Bye. Thanks for your time.
Thank
Good luck.
you.
Stay safe.
Thanks.
Bye-bye.
Bye.